What if everything you thought of health and wellness suddenly changed due to a hidden breathing problem that you were unaware of that affects every system in your body? Improper breathing habits are often overlooked in medicine. I'm Dr. Jenny from the Hobson Institute, and this is the Breathing Lab. Hi, everyone. This is Dr. Jenny from the Breathing Lab. I'm here and excited to introduce an amazing doctor, osteopathic doctor, Dr. Tasha Turzo. Thank you for joining us, Dr. Turzo.
Thank you for having me.
I'm going to just take a moment to just read your bio. Okay, so everybody understands how amazing you are. Dr. Tasha Turzo graduated from the Western University, Pomona, California in 1994, where she received a postgraduate osteopathic manual medicine anatomy fellowship. She completed her internship at the UCSF Family Medicine Residency. She's been in private practice since 1995, practicing osteopathy, homeopathy, functional medicine, prolotherapy, PRP, and specializing in craniofacial dysfunctions. Dr. Turzo has been teaching extensively in the field of craniofacial dysfunctions since 1997. She began co-treating with Dr. Nordstrom, the creator of the ALF appliance, in 1995. Dr. Turzo is a founding member of the AIE, which is the ALF Educational Institute, and has taught 38 courses to osteopaths, dentists, and myofunctional therapists. Dr. Turzo presents an on-demand 11-hour course, which is called the ALF Approach, and is an administrator of the ALF Approach Mentorship Program, which is an interprofessional online educational platform. She's internationally recognized expert in the application of osteopathy and functional dentistry, with a focus on the use of the advanced light wire functional, which is the ALF devices, and TMD. Dr. Turzo published her book, The ALF Approach, in 2020. Dr. Turzo is also the medical director of 2 nutritional IV and injectable clinics, Be Well IV. Her website is drtashaturzo.com. So thank you, Dr. Turzo, for making the time to do this. Just want to share a couple of slides really quickly so that people can see. So Dr. Turzo and I, we actually met because of my experience with the ALF. This is Dr. Nordstrom, Dr. Derek Nordstrom. If you've ever met him, he's an amazing mastermind of the ALF appliance, and we're going to talk about that in just a bit. But I've actually been to the Interface Conference and also met him at the AAMS Congress in 2015. We're going to talk about this in a little bit. This is the ALF Approach to Changing the Face of Orthodontics. This is Dr. Turzo's book. These are a little kind of crazy pictures of, this is actually my daughter going through the ALF therapy. You can see that the ALF is a little wire that fits in the mouth. It's not as big as what you see normally for palatal expanders. It fits nicely within, around the teeth. Got these little mega loops here that she can talk to us about in a little bit. And this is Dr. Turzo treating. This is actually, she's an osteopath. This is also an osteopath. And we can actually talk about that in a little bit as well. Let's talk a few questions. So Dr. Turzo, we met at the ALF Educational Institute, and I was introduced to you by Dr. James Bronson, and I had known Kathleen Winslow, who's the myofunctional therapist that teaches it, but I just wanted you to kind of explain what is the ALF, sure. and again, like when we get into it, what's the residency like? What is that all about?
Sure. So the ALF is actually there's the ALF and the ALF approach. So there's ALF appliances and ALF approach. So the ALF appliance is actually a very light wire. It's a specific kind of a wire called yellow alloy wire. And the reason why Dr. Nordstrom picked this wire is it has a flexibility to it and a stability to it that matches the support of basically the cranial base. So he was the one who created this probably about 40 years ago. He started coming to my office 30 years ago, once a month, and we started working together hands-on, four-handed patients, trying to optimize a dental appliance that actually integrated the whole body and not just move teeth, and also started to address the intraoral dysfunctions that create the crowding of the teeth. So when you look at it from a root cause, it's actually usually intraoral myofunctional dysfunctions with the lack of the range of motion of the tongue to go to the roof of the mouth, to be able to widen the mouth, widen the palate, and bring the face forward. And the ALF has no hindrances in the palate to the tongue. And so with those omega loops, what it does a little bit is it encourages the tongue to come to the roof of the mouth. And so not only are we widening the palate and creating a three-dimensional expansion that's happening, which is helping the face to come down and forward, which is how it naturally grows, but we're also integrating the root cause of the facial issues, which is decreased oral volume and crowding of the teeth. So it's a way to it's like a biometric of the tongue. So the tongue is what creates our oral volume. And so Dr. Nordstrom created an appliance that mimics basically the physiology and the physiology of the tongue. So it's something we can put in right away and get orthodontic movement, and at the same time create a 24/7 myofunctional appliance. And it also just happens to also increase cranial motion. So what you get is you get movement of the temporal bones and movement of the facial muscles, of the facial bones, that also starts to unwind the cranial strain patterns that are created because of a myofunctional dysfunction and crowding of the teeth. So it's an all-in-one package, which means it's holistic and it's integrated.
And you know, I'm a myofunctional therapist along with being a PT that treats a lot of TMJs. So what I loved about it was that it wasn't causing more myofunctional disorders while you're going through treatment. It actually helps. And
Right.
if you know that little omega loop that's right behind the front teeth or the incisal papilla, that omega loop, every swallow, if you position your tongue there, it's like it creates that natural expansion that should be happening as we grow into adulthood from being a child. So I loved it. I think that that really it's such a holistic appliance and really works with the body, and it helps kind of restore normal function of the mouth and the tongue, and the teeth start to come into a better position. So both my children and myself, actually, I started with Dr. Bronson, who is the dentist that you teach with. We started with him. We ended up with Dr. Tim Crow here in Chicago. My kids transformed around this period of time. We also knew they were tongue-tied, and got that released, and worked with the ALF, worked with the myofunctional therapy, and it got them started in the right direction. They were going the wrong way. And for me, especially, you know, I'm a little more, a little compromised because I'm an adult that was tongue-tied and had 4 bicuspid extractions taken out, and my back with the modified geld, that part of my treatment was a little modified geld that helped me create a little vertical, get my jaw in a better position. And that modified geld took away my left lower back pain, which was like, why? And I wanted to see if you could just comment on why vertical and these appliances that kind of create. I had a very deep bite myself. I'm an airway patient. I'm a breathing patient, and it helped my back. Could you comment on that?
Yeah, sure. So splints can be definitely helpful. They increase the height. So by bringing the mandible forward and increasing the height in the disc space, that also allows the neck to elongate, and that can shift everything all the way down. So, you know, we're a drop of fluid from the top of our head to the bottom of our toes. We have motion throughout our body. And now we all know about biotensegrity. So any shift and rotation in one place, whether it's through our cranium or through our pelvis, it's going to go upstream and downstream. So we're working with TMD patients. It's very important to be able to assess, where is it coming from? Where is that rotation coming from? Is it coming from the cranium? Is it coming from the jaw? Is it primarily a craniofacial dysfunction? Or is it a leg length discrepancy, you know, as you all PTs know? Or is it a twisted ankle that happened a long time ago, and now it's a walking pattern where that femur just goes internal and that twist goes all the way up? Or is it, you know, even knee issues can create it, where you have compression of osteoarthritis in the knee, and you don't have the integration of gravity going through the body in a way that the tissue can compromise for the compression that's happening, and you end up over compressing one side of the body that causes a twist in this. Scoliosis can cause it. So tongue ties will most likely for you, that's what happens. So when we're born with a tongue tie, because the tongue is tethered down like this, it doesn't have its range of motion to go up. So what it'll do is it'll bail out to be able to get to the palate. So one side will go up more than the other, like this. And in doing that, it causes a rotation in the mandible. You can see usually with someone that's a tongue tie, one of their palates will be higher than the other, and the mandible can be rotated. And so for you, just putting in a simple splint and giving you some height and equalizing you some helped with that rotation all the way down. And most likely you grew with that since you had it since birth and you functioned in that way. And our functioning is what creates our structure. Then being able to decompress the jaw joints allows your back to equalize.
So who tends to need the ALF? Just so the audience knows, like who
Yeah.
who needs the ALF appliance, like therapy? Who would
Yeah.
benefit from it?
Well, we are learning to work with, sorry, I'm managing a cat here. That's what's happening over here. Let me get the cat down.
No worries.
We are now starting to work with newborns. So we're not working with owls because there's no teeth, but
Right.
we are working with the laser and osteopathy. And in fact, just in my mentorship meeting that happened a couple of days ago, we had a dentist osteopath team in the BC area present these babies that are born super retrognathic, you know, meaning that their chin is way, way back from tongue ties. And we can work with lasers of getting the fascia released intraorally, and we can do the tongue tie release, and the osteopathy in these mandibles are just coming forward. So that's the ALF approach without the wire, right? But then we get, if we don't catch it at birth and we don't catch them and get them, you know, like your kids going in the right direction, then later on when they get teeth, the teeth are, the misalignment of the teeth is expressing the dysfunction. So the dysfunction comes first, and then the teeth come into alignment to hold the dysfunction. It's kind of like the teeth are the expression of the dysfunction, right? So in osteopathy, we're always talking about the structure-function relationship, right? We start with function. That's why if we start with babies before they have teeth, we can redirect how these teeth are going to come together. Once they have teeth and we start getting like lack of oral volume, then we need an ALF. So you can, you know, think of an ALF as like one of the many palate expanders. But the difference with the ALF is that it's going to not cause any harm because it's created to physiologically mimic the tongue and the tongue's motion. So it's in sync with the functions that create a face. And so it's not going to create asymmetrical it's not going to create compression. So basically, if you think of the body as it's biotensegrity, so everything has to move to be able to hold this shape into function. So if you put something like a rapid palate expander or a palate expander across the palate, and you do a turnkey, which is not, you know, not everyone needs the same amount of activation, but it's not individuated the way an ALF is individuated for that person. And if you turn that, you're going to get expansion this way, but you don't necessarily get the forward growth, and you also pull from the back. So anybody who has compression, the base of the cranium, or cervical issues, or even TMD, is not going to do well with a rapid motion this way of, you know, the maxilla and the palatines. So it's a integrated orthodontic appliance that addresses the dysfunction that created the structural problems.
And it's basically, if you have teeth, you can wear one, right? It's as young as, how young? would you
Well,
say?
as soon as, we've got kids that are like 3 years old that are in the
Yeah,
appliance, but they have to be
that's what I thought.
compliant. So you have to be able to get your fingers in them. And then also
Yeah,
they have to have enough height of their molars to be able to seat, a
yeah.
wire on. So before that, we have all kinds of other things that we work with in terms of redirecting. We certainly are always looking in the mouth. We're looking to make sure that there's no tethered or tissues and restrictions, and that growth is going well and they're within the range of normal growth and development.
Great. That's great. And so the ALF program that Dr. Bronson, you and Kathy Winslow do, that's something that if you're a dentist, if you're a myofunctional therapist, if you're even a physical therapist that does osteopathic work, cranial work, and an osteopath, obviously you can train with that group. The organization is called what exactly again? I'm
That's
forgetting.
AEI, the ALF Educational Institute. Yeah.
Okay.
Yes. And I think another way to start, which seems to, is probably a better way to start than going to the program. You can't go to the program, but it is the online course that I give, because that's an 11-hour online course, which is at your own time. And it goes through the whole basis of what is an ALF, presents cases, talks about cranial motion, talks about the importance of cranial motion, talks about TMD. So that's a way to kind of come on board with some basic information. And again,
That's
it's
this, right? The ALF
right.
Approach
Yes.
online course. So if
Mhm.
anybody's interested, this is you'd go to drtashaturzo.com and find this course that she's talking about. Let me go back.
And the reason
That's
why I say that
wonderful.
is just because the AEI courses are only twice a year. And they're 2 days. And so like 2024, we're not doing a level 1 course. So if someone's really, when someone's really interested and they're passionate and they want to learn something,
Yeah,
waiting 6 months for the 2 days
it's
as
hard,
opposed to jumping in and doing an online course that's the
right?
pain point. Yeah.
Okay. I have a really interesting question. By the way, we're going to get to people's questions. So if you do have a question, please put it in the chat or the Q&A section. Kiara is going to let me know about that at the end of this interview, and we can answer them. So many medical doctors and other practitioners in the medical field, at least I've experienced this, don't believe that the cranial bones move after they're fused when we grow up from being an infant to an adult. Can you comment on this?
Yeah, sure. I've got lots to say on that. So, let's see, we can talk about from a physiological perspective. Everything in the body has to have motion to be able to have lymphatic and venous drainage, right? You guys know as PTs, that's the reason why it's so important what you guys do. You're basically working on the lymphatics all the time when you can get those muscles to be optimally stretching out and compressing in. That's our venous and lymphatic flow, is the movement of our muscles. The arterial system comes in a hose that's innervated by our nervous system. And so it's not so dependent on motion, but the venous system and the lymphatic system for sure, which goes through the fascial planes, is completely dependent on motion. And so there's been this interesting discussion, even since I was in medical school, which was a long time ago, over 30 years ago, about where are the lymphatics in the brain? That was the question. It's like, okay, there's the lymphatic system. I mean, the venous system, and the venous system is held within the dura, right? So it's held in the fascia like the rest of the venous system is in the rest of the body. So we're like, okay, but nobody could find the lymphatics. And again, we all know the lymphatics are completely dependent on motion. Well, in 2015, they did a study and they found the lymphatics in the brain, and that they run along the same system, the same channels basically as the venous system. But what's interesting, when they did their research looking at the hemodynamics, it didn't make sense that there was enough pressure from the arterial system to cause the drainage of the lymphatic and the venous system. And so that is where it comes in with the cranial motion. So the cranium has motion. It actually, interestingly enough, if you look at pictures, there's a cartilaginous joint in the middle of the head until the age of 28. So until the age of 28, it's a cartilaginous joint. It fuses at 28. So there's less motion in the middle of our head, but there's still the fascia. If you study the fascia, like the inner layer of the scalp actually goes through the sutures and becomes the inner layer of the dura. And as a medical student, of course, I was very interested in anything that had to do with anatomy. And I drove from LA to San Diego because I was like 20 something and I could do that every day because it's a 2-hour drive. And I did autopsies all day. And one of the things I wanted to do was to take heads apart. So I actually was collecting data and information on SIDS in infants. So taking the cranium off and studying the dura. And I was looking at the force strain patterns in the anterior 2/3 of the falx, which attaches the ethmoid and the crista galli, and looking at kids that had sleep disturbances and how that pulled and created fibrous changes and holes in the front of the falx. And I didn't collect enough data to do any work, to do anything like published with it, but it was very interesting. And what I did find is that everything is so fluid. So when you study human beings that are like when you're in surgery or are newly dead, there's a fluidity to every single part of the body because we're 90% fluid. Even if you take bone from like in surgery when we were doing like hip replacements and you take bone and you squeeze it down, if you do it really gently, all this water will fall out of the bone. But if you do it hard, it's harder. And our cranium is meant that way. It has a fluidity and flexity because of the sutures are interdigitated like that, and there's fascia. And the reason why is so that when we fall on our heads, we have a compression here to be able to absorb the impact to be able to protect our brain. So our body is meant to be able to absorb impact to protect our organs, and our head does the same thing. So the motion is actually quite large when they're before the age of 28, because again, that cartilaginous motion, and that's the main motion is in the center. And when you go out from the periphery, everyone knows from physics, farther you go from the center, the larger the motion is out here in terms of a fulcrum. So there's cranial motion that happens. And of course, everyone knows that at birth, there's all the fontanelles and there's a lot of fascia between the bones. And the fontanelles come together and create sutures, but the sutures then have a glide and a slide to them. And again, it's all about brain drain. So that the brain has what's now called lymphatics. That's 2015. It was, named such, and it drains down to the deep cervical lymph nodes. And in fact, in chapter 6 of my book, I talk about TMD, torticollis, and its potential connection with neurodegenerative diseases. That they did these studies on rats where they took out the lymph nodes and the deep cervical lymph nodes, and what happened? The rats got brain fog and dementia.
Wow.
So any kind of restriction to the brain drain is going to cause brain fog.
Yeah. Yeah. That's great. I love that description. I wanted everybody to kind of understand what an osteopath is, a cranial osteopath, and like I see a lot of concussion patients, right? It's the injury to the skull, a blow to the skull. What happens to that act of a blow to the skull, and what does an osteopathic treatment look like? Just so that people understand. I know you use your hands, sometimes there's 4 hands, but what does a blow do, and what do you try to do to help this patient?
Sure.
In particular?
Well, so as an osteopathic physician, most of you probably know, but we're medically trained physicians. So in the United States, to be an osteopathic physician, you do 4 years of medical school and you do a residency and you work in the hospitals, and MDs and DOs all work together in their residencies. And then we specialize, right? So like my husband, who I just saw come home, he's a psychiatrist. He specialized, he did a 4-year training in psychiatry. I did mine in family medicine, but I did an extra training in cranial osteopathy. So my specialty is seen as a traditional osteopath, meaning that I use my hands first when I see a patient, and I use my hands to find the places in the body where they're restricted. Where is their lack of motion? Where is their rotations, compression, and not just in the bones, but we do the bones, muscles, ligaments, tendons, the fluid, and we treat the body as a whole integrated fluid also, from the head to the toes. So, and in that way, like we're working with breathing disorders when the thoracic diaphragm is so tight. We release the lower 6 ribs and all the ribs to help open up, especially for our sleep apnea patients. If someone's had a head injury, where is there compression within the cranium? How did this affect the cervicals? So is treating the cervicals in relationship to the cranium. For example, the upper three cervical vertebrae have dural attachments. So we can't really treat the cranium and the dura without the cervicals, and vice versa also. And the same thing with tongue disorders. You know, there is a connection between the tongue motion and the first and second cervical, specifically the first cervical vertebra. So when I'm working with my patients who are tongue-tied, I have to integrate the cervicals and the cranium and their relationship to the motion of the tongue.
That's wonderful. Like one of the things that, osteopaths, not all osteopaths are like you though, Tasha. You're amazing and you understand the mouth and the tongue and the swallow. Would you say all osteopaths understand that part?
Well, all the osteopaths that come to my courses do.
Of course they do. Well, I love this conversation. You're just you're so well versed in understanding the function. I wanted to ask you about the nasal release technique. That's a technique that I've really found very helpful, along with cranial functional manual medicine, to release that compression through wherever someone had a concussion. And a lot of dentists and practitioners are using it now to kind of help release the palate as they're going through expansion. Like, could you comment on your experience with nasal release and if you've had it done to you before, or like what do you know about that technique?
So I have not had it done to myself. I have had some patients who's had it done. I think that it's almost like if you think of the snap, crackle, pop that the chiropractors do, it's very locally specific and creating a large motion, and that it's just important to integrate it. So, and also understand like what caused the issue in the first place. If it is a rapid palate expander or an expander, in general, I'm going to say as a cranial osteopath, that's basically not a good idea. That's going to create strain patterns. Just making sure that you're clear on what created the compression that's there, and then integrating it, because the sutures are so small and fine in the face that a large motion in one area is going to have a compensation in another area. And so when we're working as a cranial osteopath, you're working with the fluid integration of all cranial bones and creating a homogeneousness in a way. It's like you want the head and the face to feel like a bowl of jello at the end of the treatment, right? And so if we have a rapid, fast movement in one area, you're not going to have that homogeneous fluid openness. You're going to have more of a compression restriction in that way, even if the system is opened. So I just think that, from my perspective as a cranial osteopath, it would be important to rebalance in a way and integrate.
Yeah. What really made this technique work well, Kathy Matias Riggs, she's an osteopathic trained physical therapist from Michigan State. That's where I've been taking courses. She would, after I'd release the patient with the nasal release, she would work on the rest of the body. And it's like that finishing with that is really, I found really, really successful and helpful for these patients. So I know we're getting close, Kiara. I was going to say we're getting close to having to stop soon, but I need to ask a couple more questions. Just real quick, breathing. How does breathing affect the lymphatic and fluid system of the body when you see like a mouth breather, a child or an adult that's mouth breathing? How does that affect our system?
It's primal and primary. Breathing, we grow as human beings to airway. This is what we do. We grow so the dysfunction that we're going to see in the body is always showing how the body's optimizing airway. So airway is the space between the back of the tongue and front of the neck. I have my chapter about body posture that talks about how that affects the tongue and the breathing, but the head forward posturing is a compensation. The open mouth breathing, as we know, doesn't initiate the thoracic diaphragm. The sternocleidomastoid is the largest lymphatic vessel, and it sits just underneath the crux of the diaphragm for a certain reason, because when that diaphragm goes down, it causes pressure changes. And so that thoracic breathing is really important. And people who have airway issues, open mouth breathing, don't have the full excursion of the thoracic diaphragm. So, and everyone, I mean, I think everyone knows now that, nasal breathing is the keystone to facial growth and development. So we can't finish a case with the
Absolutely.
ALF unless we get them with the lip seal and nasal breathing and the tongue up. So they're all related in the same reflex.
Yeah. And that's always our goal, is everybody breathing through their nose. When they get discharged, are they swallowing very gently? Are they breathing through their nose? Is their posture good? Are they walking with their arms symmetrically moving? Like, you want the fluid movement of the body and all the function.
Yes.
Two very good, important questions for people that are dealing with TMJ.
Mhm.
PRP, platelet-rich plasma injections for the TMJ. Can you explain a little bit of how you do how you treat with this type of treatment for patients that have craniofacial pain? And you can explain that.
Sure. So I don't start with doing PRP. I usually start, again, assessing the whole body and seeing, like, why does this person have TND? But let's just say that they have it because of a car accident, lateral whiplash, or even a back whiplash, and they threw a disc out, right? A TMD, TMJ disc, and that, or the lateral pterygoid was compromised because of a tear, because that's going to be ruptured if you get a strong impact from the back. And this is a primarily in injury. And then I would probably go straight to a PRP. But what I do is sometimes I'll get an MRI and assess the position of the disc. Sometimes I don't. I can use my hands to assess where I think the disc is. And it's a very tiny, tiny little needle. It goes from the outside into the joint space. And what I do is I draw people's blood and I use a centrifuge and spin it down and collect the platelets. The platelets are, what they do is they activate the cellular regeneration process. The platelets are like the ambulance. They're like the first responders when there's an accident. And so they turn on the body's capacity to start regenerating tissue. So it heals ruptured tendons, ruptured ligaments, disc displacement. So I do PRP throughout the whole body for whatever is needed, like in SI instabilities. I mean, that's a huge one. We can't stabilize the jaw joint unless the SIs are also stabilized. They go hand in hand. So it's a very small injection where I inject the platelets into the joint, and it's a way to trick the body to think that it's just been re-injured. And then the body puts forward a 4 to 6 week process of regeneration. It's highly effective. I also now am using exosomes, which is a form of stem cells, and I add that to the PRP, and that's getting even better results.
Oh, wow.
Yes.
Wow. Okay. Now, last question. And if anybody has questions, please put it in the Q&A so that we can answer them. So prolotherapy. Prolotherapy, the dextrose or sugar water injections to reduce inflammation in the joints. Some people use BOTOX. Why use Prolo versus BOTOX? And if you could explain a little bit of what that type of treatment is and how different it is from BOTOX and maybe even PRP.
Sure. Oh, wow. They're really different. So BOTOX is inhibiting the muscles, which is, it's kind of like a steroid injection. It's going to work until it doesn't work. It doesn't have a long lasting effect. It's treatment dependent, and it's inhibiting the muscles, but not dealing with underlying issues. So regenerative medicine, which there's 3 different layers to it. One's prolotherapy, the next PRP, and the next one stem cell now / exosomes. So each one of those solutions is injecting to stimulate the regeneration. So if you have instability in your jaw joint, like a hypermobility, or you have a disc displacement, the popping and clicking in the deviation, BOTOX is just inhibiting your compensation for that. So the muscles are trying to compensate to try to stabilize, but inhibiting them is just going to inhibit, and it may help with the pain, but it's not going to help heal the internal derangement of the joint itself. And so prolotherapy is a weaker solution, less expensive, a little less painful, but a weaker solution compared to PRP, and then stem cell exosomes are more effective.
So one thing I wanted to ask you, so I've had Prolo to my thumbs. My thumbs are kind of I'm hypermobile, and hypermobility, that's one treatment I've heard is very helpful to kind of help support the joints that are too loose. Is PRP also like that? Is it tighten things up to that
Yes.
are loose?
Yes.
Okay, and the exosomes too? Like all of
Yes.
it is to kind of keep things
Yes.
together?
Yep, each one is slightly different. Like PRP, prolotherapy can be a little more focused with ligaments and tendons. PRP is a
Okay.
little bit more active towards discs and osteoarthritis. So it's like if you just have hypermobility, maybe prolotherapy would be helpful. But if you have degeneration, you're probably going to need to, or disc displacement, you're probably going to need to go to the PRP. And the stem cells are much more expensive and more of a process. I don't do stem cells, but I do exosomes. And exosomes are now incredible for healing cartilaginous damages. I just had a patient who completely did not have to do surgery for a really bad
Wow.
meniscal tear. So I did 2 PRPs and I finished the third one with an exosome, and he's out running now.
Oh my goodness. And
Yeah.
so stem cells, I remember when I had my first child, they actually took stem cells from the placenta and they're
Mhm.
stored still. Is that something
Mhm.
that can actually be used for this type of thing if needed, or
No,
it's
there's a
still
whole sterility process that needs to go through. Any sort of cells that they have to be processed within a pharmacy to be able to be sterile enough for injections. So you can't take
yeah,
your own stem cells and inject them. But I do know some people will take that, freeze dried them and put them in capsules and take them. But I don't
interesting.
I don't
Interesting.
I don't know enough about that to recommend to patients. So yes. So we buy stem cells and we buy exosomes from the pharmaceutical companies
Okay.
that create them. And usually it's like a one cell line is enough to replicate them. Yeah.
Awesome. Okay. I have a couple questions here. Can you explain more about PRP? How PRP would reduce the disc,
Yes.
reduce like the swelling of the disc, maybe?
Yes. So if with in the jaw joint, it's a bilaminar disc that looks like a hammock, and it has 2 attachments, posterior and anterior. And it's usually the posterior ligament that's torn, either completely or partially, hopefully just partially. And that's why the disc is forward and out of place. It can be, the anterior one can be damaged and it can be posterior. So when you go into the joint capsule, go through the joint capsules into the joint space, and you put the PRP, it helps to regenerate those ligaments and helps to stabilize the disc into place on top of the
Okay.
condyle.
And then I have another one from Terry Campbell. This is who is eligible to take Dr. Turzo online course? Is there
Everybody.
anybody?
That is
Everybody. And you
why I
said
created
patients
it.
too, right?
Yes, that is why I created it. I wanted this information to get out to everybody. And so that course, anybody can go on and take the course.
Awesome.
And the
Awesome.
book is available through Amazon also.
Yes, let me go back to those slides real quick. Anybody have any other questions? Because I'm going to kind of end in a moment. And I just wanted to make
I
a
should
couple
say one thing I
announcements.
just thought of
Yeah.
is the book and the online course have different information in it.
Okay.
The book I wrote as a resource guide, so for parents, but also as you go further into the book, it gets more practitioner interesting. But the online course is very heavy in anatomy and physiology and shows a lot of cases of the ALF and talks about how to treat TMD and so forth. So it's more practitioner suggested.
Okay. All right. I'm going to look if there's any more questions before okay. So, first of all, thank you so much.
Yes.
We're going to end very soon, so I just wanted to say I appreciate you. I love all that you're up to, and you're an amazing physician, and I love how much you're sharing with everybody. You're really trying to make a difference, so I
Yes.
really appreciate all that you're up to. So,
Yes. And thank you
thank
so
you.
much for inviting me. I really appreciate the opportunity to share. So thank you.
Yes, you're welcome. You're welcome. Hopefully, we can do it again at some point in the future. I'm just going to end with I'm actually creating my own courses right now. I'm carving out a week out of every month to write, and it's going to be something that a coursework that I've created around TMJ and really airway. So many physical therapists and speech therapists and dentists and medical doctors really don't understand all of this. So it's going to be really for the medical community. And from my point of view as a physical therapist. So if anybody's interested, you can at least get if you get the QR code, you'll get on a listserv to be notified when that is ready to go, my first airway course. And finally, my next podcast is with Dr. Harry van Piekart, who is an amazing physical therapist from Holland, where I studied. And we did one with Dr. Jan Damerholt just last month, and we had a few technical difficulties because he was in Germany and he couldn't log on to the Zoom. And now we've worked out the kinks, and he's going to be on and live and with the video, not just with the WhatsApp. So I hope you all can make that. Look out for an invitation in your email for that. And yes, thank you so much. This is, if you're interested in getting a hold of me, this is how you can get a hold of me. I'm actually also on TikTok doing a lot of breathing tips. If anybody wants to follow me on TikTok at the Hobson Institute, but these are all of my social media links for you to connect with me. All right. Thank you all for your listening, and I look forward to our next podcast. And I appreciate all that everybody's up to. And thank you so much, Dr. Turzo.
Thank you.
Thank you for listening to the Breathing Lab with Dr. Jenny.